Dr. Burkey received her undergraduate degree at Dartmouth College, followed by medical school at New York Medical College. As we all know, Carolyn did her residency here at UW. As a resident, in addition to excelling in her clinical studies, she was active in numerous hematology and oncology research projects, an active participant in our Teach Pathway, and engaged in numerous community service activities here in the greater Madison area. As both a resident and a chief resident, Carolyn has had two areas of sort of scholarly interest beyond hematology and oncology. One is interprofessional education, which we'll hear about today. The other is sort of assessing the role of gender bias in evaluations and creating strategies to mitigate that bias. She's spoken on that topic both locally and nationally. As a chief resident, Carolyn has excelled as a teacher, mentor, friend, role model, and really has been an outstanding leader for our program. I am certainly incredibly grateful for all that Carolyn has invested in our program, and I know her leadership, her kindness, her innovation have made us a much better place to train. So I am incredibly excited to hear about this talk today, interprofessional education and collaboration as tools for achieving the quadruple aim. Thankfully, Carolyn will not be leaving us. She'll be continuing on here at UW-SFL in hematology and oncology in the next academic year. So please join me in welcoming Dr. Carolyn Burkey as today's grand round speaker.
Thanks, Sandy. I hope I can live up to all of those wonderful accolades. I'm so excited to be talking to you guys today about a topic that I'm very, very passionate about, which is interprofessional education. Not sure that the clicker works, sorry. Okay, perfect. So just some financial disclosures. I have no relevant financial disclosures to discuss. And just wanted to go through some of our learning objectives for today. And so I hope that by the end of this talk that you're able to define some of the key terms with interprofessional education and collaboration. I also hope that you're able to understand the quadruple aim of healthcare and are able to interpret some key studies that show that interprofessional education is one of the ways that we can try to achieve that quadruple aim. And most importantly, I hope that you come away with just a respect for the other people within our healthcare system. There are a lot of people that work together to take good care of our patients. And I think it's really important to recognize that healthcare really is a team sport. So with that, let's go ahead and get started. This is our roadmap for today. I'll tell you a little bit about how I got interested in this topic. We'll talk about the history of the quadruple aim. We'll review some of the relevant literature. And then I'll talk to you about my chief project and give you some concluding remarks. So let me take you back to the end of my intern year. By that point of the year, I had mastered the two most important skills expected of me by my senior residents. One, I was able to pull out a pen and create a checklist at a moment's notice. And two, I was very, very good at getting my notes done and my tasks done efficiently so that we could sign out on time. By the end of my intern year, I was very proud of myself for my efficiency. But on the night before my PGY2 year, I had a lot of first day school jitters. And all of my fears were centered around holding the code pager, about taking care of decompensating patients, and whether I would be able to manage an intern while they were doing admissions and physicals. So in short, all of my fears centered around my performance in the hospital. But the first day in clinic as PGY2, my mentor, Dr. Schiffler, gathered the group of us at 1102 South Park. This is back in the old model where we still went to clinic for a half day every week. And for those of you who don't know Dr. Schiffler, he's in the crowd right now, so I'm going to embarrass him. But he is the most compassionate and thoughtful and intentional physician that I've had the privilege to work with. And I'm really thankful for him. And he also keeps up to date with all of the latest teaching techniques. So at that time, SMART goals were all the rage, and all the other attendings that I was working with were asking me to assign myself SMART goals. So Dr. Schiffler also did that, but he also told everyone in our clinic group that we needed to start working together as a team with the other people in our clinic who are not providers. And so he wanted us to practice team-based care. And now for those of you who know me well, you know that I am horrible with names, and the number of patients that we were expected to see in clinic was already increasing. And so I felt woefully unprepared for doing that and also trying to get to know the other people in clinic. I also wasn't sure exactly what Dr. Schiffler wanted me to do, but I knew Dr. Schiffler and I trusted him. And over the years, he guided me through the process of practicing team-based care. And I'm just going to give you a few examples of how this worked. So one of my favorite patients is a patient who loves Mountain Dew. He drinks 2 liters of Mountain Dew a day. And as a result of his Mountain Dew drinking habit, he has diabetes and chronic kidney disease. And now, as his physician, it was my job to try to help control some of those diseases. And I did everything. I changed his medications. I talked to his family. I pleaded with his daughter and tried to get verbal contracts that he would stop drinking his Mountain Dew. And nothing that I did seemed to work until one day, Dr. Schiffler introduced me to Ann May, who is our clinic pharmacist. This is not Ann May, of course, just some stock photos. But Ann May was able to help him make sense of his disease and his medications in a way that I was never able to. In another example, I had a patient who transferred from another healthcare system, and they were taking ADHD medications. It was my first time dealing with restricted drug contracts, and Dr. Schiffler introduced me to Kat, who was our nurse in clinic. And Kat was able to walk both me and the patient through drug contracts in a very easy and simple way. In the last example, at our clinic, we had a lot of patients who have anxiety and depression. And so he was able to introduce me to Eric, who is our on-site behavioral health clinician. And soon, warm handoffs during the course of clinic became the norm and not the exception. And through all of these different experiences, I started to notice 3 main things. The first thing that I noticed was that I liked going to clinic now. I felt like I was going to work with friends and people who actually knew me. The second was that my patients were enjoying clinic experiences more as well. They felt like they were getting more value. They were not just seeing me as the provider, but they were seeing other people too, and they felt more comfortable. And third, and probably most importantly, my patients were actually doing better. So that patient with the Mountain Dew drinking habit, his A1C improved by over 2 points as a result. And the only thing that I can attribute that to with that time period was him working with both me and our clinic pharmacist. Some of my patients with severe anxiety and depression were starting to come off their medications for the first time, and it was truly impressive. And so, through the wise counsel of Dr. Schiffler and others, I learned a lot about what it looks like to practice high-quality team-based care, and it's completely changed the way that I view medicine. And so with that, we're going to talk a little bit about the history of the quadruple aim. But before we do, I want to touch on some definitions so that we're all working from the same foundation. So there are 3 main terms that I want to differentiate because we sometimes use them interchangeably, but in their literature, their definition is more specific. And we'll define each of them by the focus of the team members as well as their perspective on collaboration. So let's start with a multidisciplinary team. A multidisciplinary team is one where there are a lot of different team members and healthcare workers, but they work within their disciplines with little to no collaboration. So let me give you an example. Imagine that there is a child who has pretty severe asthma, and she gets hospitalized pretty frequently as a result of her asthma exacerbations. So she might have an allergist who helps take care of some of her asthma medications. She might have a PCP who helps with her vaccines. She might also have a physical therapist who helps with her physical health and strength. But no one is really communicating much in the same way. They're all just working kind of independently. An interdisciplinary team takes that one step further, and their focus is more holistic. So they collaborate extensively to take good care of patients. And their perspective on collaboration is more of a team-based care. So as you can imagine, this might be an example like an asthma clinic where they have a dedicated team to kind of take care of this patient together. This might include an allergist, a social worker, a pharmacist, and more. And as a result of working together, what they might need to do is reprioritize some of their own individual goals as a result. The last example is a transdisciplinary approach, and this takes it one step further. So transdisciplinary teams are at the highest level, and this is where teams are starting to get creative in their makeup. An example would be something that happened this year where one of our senior residents, Dr. David Deemer, collaborated with some physicians, some hospital administrators, national organizations, and government leaders to introduce a bill, AB 914, which actually introduced inhalers to medical kits at schools. So thank you, David. He's in the crowd right now. And thank you to all these awesome people who did this. The last few definitions I want to give are about the difference between interprofessional education and interprofessional collaboration. And really the difference is between learning about something and actually taking it and putting it into practice. And so interprofessional collaboration is just that. And so now that we have the definitions out of the way, let's go ahead and dive in. So let me take you back to 2007. This was a tumultuous time in healthcare, a time of dramatic change. In the 1990s and early 2000s, we started to understand how much chronic healthcare conditions were starting to cost our country, as in billions of dollars per year. And unsurprisingly, people started to recognize that this would be untenable in the long term. As a result, the strategic focus of our country went from focusing on the patient experience to thinking about how to improve population health and the value for our money. Don Berwick and some other members of the Institute for Healthcare Improvement implemented this idea in 2007. And as a result of the Affordable Care Act, in 2010, this actually became part of our national strategy for healthcare. But problems started to exist. Healthcare workers stepped back and started to take a pulse on their own health. And data started trickling in about the challenges of working within the healthcare system for our over 22+ million employees in the healthcare sector in the United States. One study reported that 7 out of 10 PCPs would have chosen a different specialty if they had a choice. And the reason for that was largely due to administrative burdens. 1/3 of nurses started reporting significant burnout. And about 1/3 of employees altogether in the healthcare workforce said that they wanted to exit the healthcare industry altogether. And so in 2014, a study published by Dr. Bodenheimer and Dr. Christine Sinsky, who actually was one of our Grand Round speakers this year, introduced that 4th pillar, improved provider experience. And as a nation, we started to recognize that in order to maintain high quality healthcare, we had to start taking care of our healthcare workforce so that they were able to have the motivation and energy to take good care of our patients. And so with that, we're going to go ahead and start reviewing some of the literature. And specifically, we're going to review the literature and examine some studies based off of this quadruple aim. Because as I was starting to think about my chief year, I started to wonder if the experiences that I had had in clinic were just unique to myself, or whether these were experiences that other people had started having as well. And so we will go through each of the pillars, and we'll talk about 1 to 2 studies for each so that I don't bore you guys too much. So improved provider experience is the first one, and it's perhaps the most obvious way how interprofessional collaboration helps. So the first study we'll talk about is this one. In 2009, the Cambridge Health Alliance has started to transform all of its 12 primary care sites into patient-centered medical homes. And for those of you who aren't familiar with the concept of a patient-centered medical home, it's a care delivery model that focuses on providing comprehensive care. This means that in order to get this designation, the facility has to focus on all of these different facets, including acute, chronic, and preventive care. They have to have care that's also convenient for the patient. So if you have a question in the middle of the night, you have someone you can call. And if you have an emergent need, you're able to get in and see the doctor earlier. It has to be accountable, which means that you have to practice evidence-based medicine and have some good clinical decision support tools at hand. And you also have to have coordinated care, which means that you're able to navigate transitions from the clinic to the nursing home to the hospital and more. In short, this is a pretty tall order, and this is a really hard thing for people to do. It's a perfect environment for interprofessional collaboration and for team-based care to come into play. And so the study itself was the Cambridge Health Alliance, and there was 140,000 patients involved. There were 12 primary care practices, as I mentioned, that were transitioning to these patient-centered medical homes. And as part of the study authors designed a 55-item survey where they were looking at perceptions of the healthcare workers on teamwork, care team behaviors, job satisfaction, burnout, and leadership. And the primary outcome that they looked at was the perception of teamwork, low versus high. And they found that a lot of the patient-centered medical homes that were pretty advanced in the process of transitioning were more likely to have high-quality teamwork. But they also found this. So in the middle, this higher practice teamwork perception is all the healthcare workers that said that they thought that the teamwork was really high in their facility. And then here's the low practice teamwork perception. And what you can see here is that individuals who rated their facility's teamwork as very high were twice as likely to have high job satisfaction. They were also half as likely to report severe burnout. And importantly, they also felt like their leadership was good in their clinic, and they felt like they had the support of their team. And so some key points from this study is that the perception of higher teamwork is actually protective. You can have improved job satisfaction, you can have decreased burnout, and your perception of your leadership can be positive. But as you'll see with a lot of these studies, there are some limitations. So this was a single health system. It focuses on one care delivery model, which is the patient-centered medical home. That's not always possible for a lot of people because transitioning to a patient-centered medical home is very expensive. It takes a lot of resources from staff, and it also takes a lot of financial resources as well. The next study that I'll talk about is this study from 2004. And so at this time, crew resource management training had made headlines for improving the safety of our aviation industry. And the healthcare industry had started to recognize that many of the principles and frameworks from the aviation industry could actually be adopted for the healthcare space. And as a result, several providers at Kaiser spent time training 12 clinical teams, and they asked them to go ahead and apply those findings in independent projects. And some of the tools that they taught were things like this. So the United Airlines had come up with cuss words, which wasn't listening to profanity, but rather tuning in when nurses or other healthcare professionals started saying statements like, "I'm concerned," or "I'm uncomfortable," or "this is unsafe." Another framework that they introduced was the SBAR method, which was actually developed by the Department of Defense. And it was in response to situations where the military was dealing with real-time conflict, where they could give recommendations in real time. And there were a lot of great projects that were implemented at Kaiser during this time, but we're actually going to focus just on one of them. So this is a project where an interdisciplinary team talked to all the people who are involved in a surgery in a given day. And they created this debriefing tool where they asked everyone what they needed to know about the surgery in order to provide good care. And they found that by implementing this tool, there were a lot of benefits. From a quality and safety perspective, they actually had 0 wrong site surgeries afterwards, which is awesome. But importantly, they also saw a lot of improvement for nurses. So nurse turnover decreased by 16%. Job satisfaction improved by almost 20%. And very importantly, OR nurses felt like they were valued in the OR. 80% actually reported that. And so what you can see from this is that interdisciplinary work is actually really effective. It improves provider satisfaction, but it also improves patient safety. And again, another study limitation. This is also a single institution study. It's also observational. You'll kind of hear me repeating that over and over again. So as we mentioned earlier, it makes sense that team-based care makes you feel good because you feel like you're a part of a team. But we still have to understand whether or not this actually helps for the other aspects of the quadruple aim. And so next, we're going to transition to talking about the patient experience. And the first study we'll look at is from 2018 in the New England Journal of Medicine. So this study looked at 5 medical ICUs that were part of the University of Pittsburgh Medical Center system. And they identified families of patients who are very high risk of morbidity and mortality. They also picked only families that had a known surrogate decision maker. So there are some things here that might play into the results. The intervention that they carried out was by an interprofessional team. So they took each of the 5 ICU sites and they identified 4 to 6 nurses that were known for their strong communication skills. And then they trained them even further in communication and techniques. And then they had these nurses oversee this interprofessional team. And within 48 hours of the patient being admitted to the ICU, this interprofessional team met together with the patient's family and they talked about their course. And then they also met together every 5 to 7 days thereafterwards. It was a stepped wedge cluster randomized trial. And essentially what that means is that the study authors recognized that once they started the intervention at the ICU, that they would probably be changing the course of how people would be interacting at that ICU. And so the control group was all of the ICUs where the intervention had not yet begun. And then people slowly were introduced into the study. The primary outcome was surrogate psychosocial distress at 6 months. Some few caveats here. So they did find some differences in baseline characteristics between the intervention and control group. Namely, the intervention group was a little bit older, and they also had more medical illnesses and comorbidities. And this last one is also probably important. They were more likely to have a non-spouse as their surrogate decision maker. So some confounding factors that might play into the way that we interpret this data. But let's still march ahead and go ahead and look at the data. So these are some clinical outcomes. And some of the things that they noticed after they adjusted for the differences in baseline characteristics was that the intervention group was actually more likely to die in the hospital, about 36%. But then when you look at death at 6 months, it was not significant. So there was actually a significant amount of death in both groups. And then when you looked at living independently at home at 6 months, this was really low and also really sad to think that this was the case. And they also found no differences in their primary outcome of psychosocial distress at 6 months. What they did find was 3 things, however. So they gave surveys to all of the family members, and one of them was this quality of communication score. And so higher scores are better. And what we can see is as a result of the intervention, families felt like the quality of communication between the healthcare team and the patient's family was a lot better. There's also this modified patient-centeredness score. And this is a little confusing because lower scores are actually better for this one. And so with the intervention, they saw that there was a lower score and it was statistically significant as well. So the care that the patients were receiving was more patient-centered. And then last thing that we noticed was that there was a decrease in the length of ICU stay and a decrease in the length of hospital stay as well. And the conclusion that the study authors made here actually was that as a result of the intervention, patients' families were more likely to transition the patients to comfort-focused care if that aligned with the patient's wishes. And so it actually helped with healthcare utilization as well. So some key points here, they didn't see any improvement in psychological symptoms for caregivers. At baseline, some of these caregivers didn't have as much psychological burden as other studies have shown. So maybe didn't have the best baseline data here. But they did see improved perception of quality of communication and improved perception of patient-centered care and a decrease in hospital utilization. Again, there are some differences in baseline characteristics, and all the patients and families were from the same region. And so there might be some confounding factors here. The second study that I'll talk about is actually completely switching gears. So as you can imagine, the ICU is often a very collaborative environment. And so it's not really surprising that patients and their families there benefit from strong teamwork and communication. But this is a study of children with severe and chronic pain. So in this study, there was an intensive inpatient interdisciplinary pain program, and hospitalists, mental health therapists, pediatricians, social workers, and more all worked together to create a pain management plan. And then they also taught the kids strategies to cope with their pain in case the medications and all the other treatments didn't work. And there were 120 kids who went through the program, and all did eventually receive the intervention, which is important here. You'll kind of see the data as post 6 months and post 12 months after intervention, but it's kind of confusing because everybody received the intervention at some point. So the biggest difference is in the directly post-intervention period. The primary outcome that they looked at was a combined endpoint, an improvement in pain intensity, school absences, pain-related disability, and some mental health factors such as anxiety, depression, and more. And so directly after intervention, they did see a pretty significant improvement in the intervention group. And what they specifically saw, and I didn't show the data here because the tables are a little confusing, but they saw an improvement in school absences. So the kids went from missing school about 3 days within the 4 weeks to missing no days of school. They also saw an improvement in pain-related disability as well, as reported by the children. There was no immediate change in anxiety, depression, or pain intensity, but 6 to 12 months later, there was an improvement in all the variables. And so they did find that there was a lasting effect as a result of the intervention. And so those are the main points that they found here: decreased school absences and disability. Some study limitations here as well. These were self-reported changes, and so might have suffered from subjective bias and some Hawthorne effect. Also some potential recall bias as well. And then because of the way that the study was designed, the comparison was between that weighting control group and the intervention group. And they did this because there were other studies that had kind of done it the same way. So there was some precedent for it, but it makes it a little bit confusing to interpret that data. So the third pillar that we'll talk about now is lower cost of care. And this is a study that came out in 2019 in the Annals of Family Medicine. And in 2017, Creighton University had created a new ambulatory care center. And it allowed them a fresh start where they could focus on an interprofessional collaborative care model. Some of the key features that they started including were daily huddles in the morning and afternoon clinic, where team members had the opportunity to talk about important safety issues, share announcements, and celebrate highs and lows. There was also dedicated time for residents, faculty, and medical assistants to do pre-visit planning, where they could talk about their important needs for their patients. Warm handoffs during the course of clinic were actually encouraged, where if there were interprofessional team members, you're recommended to go walk the patient over and talk to them. And then weekly conferences were also encouraged as well, where they did a safety conference and they talked about the high-risk patients. And they actually came up with a safety plan once a week for those patients that were most high risk. And so in this study, they identified a high-risk patient cohort. And these were patients who had had 3+ emergency department visits within 6 months. They had an A1C, or they had an A1C greater than 9%, or they had this LACE score greater than 10, which is essentially the hospital readmission risk score. And so here are the patient's baseline demographic characteristics. And as I mentioned, the study took place at Creighton University. And so this is the state of Nebraska. And some things that I want to point out here is that in this high-risk patient cohort, you see an overrepresentation of Black patients and refugees, which shows that there are some systemic factors at play here too. But here's the data for the new ambulatory care center. So as I mentioned, in 2016, this was the old model. And then in 2017, that new ambulatory care center had been built. And this is data from the ambulatory care center year. And so as you can see, there was a dramatic improvement kind of across the board. ED visits decreased by a significant percentage for these patients. They were less likely to be hospitalized, their A1C improved, and total patient charges actually were cut in half, which is very impressive. And so again, some major study limitations here. This was a new ambulatory care center. So as you can imagine, that may have led to some confounding factors. Everyone gets excited about something that is new. And so it's easy to do that. And so maybe there were some things here that could have messed with the data, but still very impressive data. It's a single center study and it's non-randomized. So the last pillar that we'll talk about now is improved patient outcomes. So in the previous study, we did see some improved patient outcomes. So we're only going to talk about one study here. And this was a study that was published in JAMA in 2016. So in this study, they looked at the Intermountain Health Group, which was transitioning its facilities to an integrated team-based care model. And over nearly a decade, several practices had underwent transition towards this team-based care model. and it was specifically focused on mental health integration. So this included mental health providers, PCPs, behavioral health therapists, operations managers, and more. And they identified patients who had seen a PCP between the years of 2003 and 2005. And then they followed these patients for anyone who had had at least one care visit annually, even if that was something as simple as a blood draw. And these patients had to have one care visit annually for 10 years. And then they looked at the outcomes several years after they had implemented this transition. So 2010 to 2013, they looked at 3 years of data. And what they saw was, I know this table is small, but what they saw was a significant improvement in the rates of depression screening among patients with active depression. And they also saw an improvement in self-care plans. So here, this is the number of team-based care events, and then this is traditional practice model. So this is the intervention group, and this is the control group here. Depression screening almost doubled. Documented self-care plans went from 9% to 48%, so pretty significant. And then they also saw an improvement in adherence to a diabetes bundle, which was also part of the intervention as well. People were more likely to stick with their medications and their treatments. All of these top ones were very significant. And most impressively, there was actually a significant improvement in healthcare utilization pretty much across the board. So again, similar to what we had seen in the previous study. Hospital admissions decreased dramatically. ED visits also as well. And primary care visits even decreased, which is good for our primary care providers who are already overworked. And then lastly, payments received also decreased for the individuals. And importantly, one thing to note here was they actually took a look at how much it cost for them to implement this new integrative model. And they found that patients saved more money than it cost them to actually implement the model. So it was better for the healthcare system overall. It's one of the few studies that actually did that. It cost about $9 per patient to do this. And so here's some study limitations. There were some differences in the baseline characteristics. The people in the intervention were more likely to have depression, so maybe that confounded the data a little bit. And again, this is an observational study. Unfortunately, it's hard to do these kinds of studies in a randomized way. And so with that, I wanted to tell you a little bit about my chief project and the thing that a lot of the interns have been part of this year. So these are the core competencies from the Interprofessional Education Collaborative. And they took all of these different values and said that they were really important for us to utilize when we're thinking about a project that has a focus on interprofessional education and collaboration. And so when I was looking at my project, I was hoping to incorporate a lot of these values, including mutual respect, roles and responsibilities, understanding your place and understanding another person's place in the healthcare system, communicating well and feeling like communication was responsive and respectable, and then having high quality teamwork. And so I'm going to tell you a little bit now about the Interprofessional Education Workshop. And thank you to all the interns in the room who actually were part of this. So given we were piloting this idea, we decided to focus on only a few of the competencies. And we specifically hoped that the interns would, one, have the opportunity to spend one-on-one time with some awesome colleagues in our healthcare system. And two, come away with some really practical things that they could use, such as we focused on the upper extremity exam. And so physical exam maneuvers related to that. So the workshop structure included rotating groups with 3 different groups of health professions employees. We had the VA hospital lend a lot of their staff. And so physical therapy, occupational therapy, and ICU nurses from the VA helped us out. And they focused on discussing specifically how they would handle that first consult appointment. So physical therapy, you have to laugh it off, right? Or ignore it. So physical therapy, they focused on discussing what they would do in that first initial appointment. So let's say that you had a patient in clinic where you came in and they had an upper extremity MSK complaint. And normally the way that I handle that is like, okay, great. I don't need to order an MRI, so call physical therapy. And so physical therapy told us what they would do once you put in that consult and how they would take it from there. And it was really great because the interns actually got to try out some physical exam skills as a result. Similarly, occupational therapy finally explained to me for the first time what they do in the hospital, and I felt like I understood it. And they also brought some props so that we could understand some of the cool gadgets that they're able to give our patients. And then the ICU nurses came and we had this shared perspective taking exercise where we got to talk a little bit about the day in the life of a resident and the day in the life of an ICU nurse. And then we had the opportunity to ask questions about why ICU nurses might prefer us to do certain things at a certain time versus like how we would like things to be done. And so it was actually a really great discussion. And then the last piece was an advanced practice clinician panel, which Chris and Panther helped me lead. And so we had a lot of wonderful APCs from across the hospital system who came and kind of shared a little bit about what they do in our hospital, which was really awesome. And so this is the data from the workshop. And thanks to the surveys that the interns filled out, so about 60% of the interns had the chance to participate this year, and they were asked to fill out some questionnaires that were based on some validated instruments to assess the effectiveness of an interprofessional education intervention. And the questions specifically were related to attitudes towards interprofessional education, role clarity about what each person of an interprofessional team does, understanding of how other professionals are trained, and thoughts as to whether interprofessional education improves patient care. So a few big takeaways is that for a lot of these, blue is pre-workshop and then red is post-workshop. And for a lot of these, our residents were already scoring really high across the board, which actually shows a lot because it means that our residents really care about interprofessional collaboration and teamwork in healthcare. But across the board, the workshop moved the needle towards this higher score. And I think that shows that it was pretty effective. The things that changed the most were this comprehension of training of other disciplines, where we felt like we understood better how other people were trained, including their undergraduate and graduate training. And then the role of interprofessional education improving healthcare costs improved as well. And role clarity, people felt like they understood for the first time, like I did, what occupational therapy does more. And so it was really helpful. And then our workshops are always rated really high, but I thought that this also was helpful is that 21 out of 22 interns said that they wanted a similar workshop next year. And then some quick selected feedback from the free-form answers that residents gave. We specifically saw some improvements in role clarity, as I mentioned, especially with physical therapy and occupational therapy. And they also felt like they were able to come away with some useful exam maneuvers as well. And so next year, we hope to add to this pilot even more by increasing the number of healthcare professionals. And so we're hoping to add nutritionists, pharmacists, social workers, speech and language pathologists, and more. And so if you know anyone who might be interested, or if you yourself are interested, please reach out to me because we would love to have more professionals involved. And so with that, I just want to wrap up with some concluding remarks. And so this is Charles Van Heis, who is the president of the UW system in 1904. And he was the first person to promote the Wisconsin idea, which is that we take everything that we learn in our vocation and our studies, and we use that to improve the government, economy, and the lives of people in our state. And so this year, I've actually had the wonderful and enormous privilege of living a very integrated life. And so I have been able to participate in a free entrepreneurship program through the university to found a medical education software company that focuses on teamwork training skills. And these are some pictures from my graduation with my mentor, Amy, who's here, so thank you. And then also a lot of awesome female founders and mentors as well through the programs. And so I wanted to end with the 3 biggest lessons that I've learned from my unexpected entrepreneurship journey. And the first lesson that I have learned is the importance of asking the right questions. So there's a very famous book in the startup world that's called The Mom Test. And it talks about how to talk to customers when you're trying to figure out a good idea. And it's built around the principle that people like to tell you the wrong thing. So they're always lying to you because you're asking them to their face whether or not they like your idea. And instead, it tells you to focus on 3 main principles instead. They recommend that you talk about their life instead of yours. They ask you to ask about specifics that happened in the past, specific behaviors, specific actions, instead of generics or opinions about the future. And they recommend that you talk less as a whole and that you listen more. And one of the best quotes from the book is that whenever someone says, I will definitely do X for an idea that you're pitching, they're almost certainly lying to you, because people are very, very bad at predicting their future behaviors, and they will tell you anything to get you to stop talking. Lesson number 2 that I have learned is to put my name in the hat. So prior to chief year, I was a really quiet resident. I did not really apply for many things. I did not try for many things. And the chief year has actually helped me to feel very comfortable in front of a crowd and to feel more confident. But I ultimately decided to apply for my chief year because I really love this residency program, and it's been like an amazing blessing. Like Luke and I talk about this all the time, is that I have learned so much during residency, and I have enjoyed the process, even during the hard nights of intern year, even during 28-hour calls. I come home and I'm like on caffeine because I'm just so excited about how my day went. And so it's been a really awesome experience. But one of the reasons why it's really important to put your name in the hat is some of that other work that Andy was talking about with my gender bias research and things. Women are a lot less likely to put their names in the hat if they feel like they don't meet the qualifications. And the reason for that is because they're worried that they might fail, and they're worried about how that will impact themselves. And so this is a study from the Harvard Business Review, and it's pretty old at this point. And so this brings me to my third and final point. In the startup world, we're encouraged to fail, and we're encouraged to fail often and to fail quickly. And I have failed so many times. Like, we have changed our idea 1,000 times, and I've worked on presentations and pitch decks and more so many times as a result of feedback that I have received. And so I love this quote: if you never know failure, you will never know success. I've learned to be okay with failure and to be okay when things go wrong. And it's been such a fun journey because I know that my startup will probably fail, because most do. But I have learned so much during the process, and it's been so much fun. And I've gotten to meet so many wonderful people along the way. And I know that these lessons will really pay off in the future. And so with that, I have a lot of thank yous. So I want to conclude with some very important ones, and I'm probably missing people. So thank you to everyone who is part of this interprofessional education workshop. These are just some of the people. I didn't list all our APCs because there were many. And then all of the interns who participated as well. Thank you for being my guinea pig. I appreciate you guys. Thank you to these mentors who have been really wonderful and have really supported me throughout the process of my residency. They have cared a lot about me as a person, which has really been valuable. Thank you to Amy and everyone else in that Igniter cohort. I've learned so much from them. Our residency team as a whole, we have a lot of admin staff, Dr. Schnapp, Andy as well. So thank you. And then our residents who make everything wonderful. It's been really, really awesome, actually. I wouldn't be here I really wouldn't be here if I didn't enjoy my residency program, but I didn't enjoy my residence. So thank you so much for coming and listening and learning from my morning reports and all of my teaching sessions. So it's been great. And then most importantly, thank you to these people. So Kelsey, Amy, and Mike, thank you for an awesome year. When I think about team-based work, I feel like we work together really well as a team, and it's been really fun through this process. And so I've enjoyed going to work every day. You guys know everything about my lives, probably a little too much. And I'm really gonna miss our office moments next year. And then to my family, thank you for always supporting me. Charlie is right here, and this is baby Anna. And then everyone else as well, and especially to my husband, Luke, who's been kind of through this whole process. He has listened to so many talks and reports and has watched the kids during many and many call shifts. So thank you. And with that, I'm happy to take some questions.
All right, great. Thanks, Carolyn, for a wonderful grand rounds. We'll take questions from the audience. See one already from, I'll get Tom. He was a featured participant in the talk, so I gotta let him talk.
Thanks. Yeah. And Caroline, I think you undersold my role in your presentation. So thank you so much. The respect is very mutual. Question, and I wonder about your advice for those of us who like teach team-based care. Would it have been helpful, and I may know the answer from the last couple of slides, but would it have been helpful for us to have really pushed that and taught that from day one? Because I think about your experience compared to like Tyler actually has to walk past Ann May to get to talk to me, and we huddle with our MA Rochelle in clinic. So it's actually very different. But I wonder what you think about that.
Yeah, that's a great question. So I think it's hard during the first couple months of intern year, right? Because during that time, it feels like you're drinking from a hose. And so you're trying to still figure out how to deal with the electronic medical record and other things. But when we model these behaviors kind of from the start, we pick up on those things from the outset. And so I think there's a fine balance between actually teaching those skills directly right away as soon as people start, and just modeling them and letting people kind of pick up on it, and then showing them, hey, this is the reason why we do these huddles with the medical assistants. This is the reason why we're actually all co-located in one space. So for those of the people who haven't been in 1102, we have this giant like room and everybody sits together. It's a like even playing field. And so you're constantly interfacing with the same people. And so there's not as much time for that in crowd speak because you're already working together as a whole. So I think modeling it is really important, but actually taking the time to teach it might be like a little bit of a later, more senior and advanced skill, if that makes sense. That's just my opinion.
Wonderful job, Carolyn.
Thanks,
You
Dr. Burkey.
warm my heart to hear your discussions about teams. Teams, of course, are dynamic, and we know there's that norming, forming, norming, storming, and then ultimately performing. But that process doesn't exactly follow that loop exactly. And what I'm wondering is, with the work you've done and with some of the initiatives you're doing, how have you approached kind of team dynamics, especially when there might be tension within team members? You've alluded to some of these power differentials and other matters, but I think it's so important to be thinking about the work of maintaining a healthy team. So can you just comment a little bit on some of your thoughts?
Yeah, absolutely. So there are a lot of great studies that take a look at how to promote team-based care kind of after the intervention has been in place. And the most important things that they identify are having strong leaders. And so actually taking like 2 to 3 people who will kind of be the champion for team-based care in that environment. And you continue to train them and you continue to invest in them so that they promote that healthy culture. It's kind of their job to do that. And what that entails is organization buy-in, right? So you need people kind of at the administrative level who say, hey, this is important to us. We see all of these values and we see all of these effects that it has. And so we are going to take that and we're going to have like someone whose like role is to do that and to make sure that we're continuing to do this well. So that's hard because not everyone is able to do that, right? And like if you imagine like a small clinic, like it might be hard to have the same thing. And so the other piece that they talk about is like a lot of that co-location that I was talking about, where you have that big room and like everybody is working kind of in the same space. Because as you can imagine, you can't really talk about someone negatively if they're like right next to you. You kind of have to be friends. You're a little bit forced to at least be collegial with one another. And so that helps a lot in terms of environment too. But there is a lot of, I think there's a lot of this where it's just like respect, right? It's like respect for the other people like who are in our healthcare system. And so you can't always teach people to play nice in the sandbox, but you should maybe try because it'll make your life better and other people's lives better too. So that's my
Great. Well, wonderful talk and congratulations on really a wonderful presentation. Clearly a lot of heart and soul in it, which I love. I'm going to follow up a little bit on Steve's question, and you mentioned how important co-localization is. In the post-COVID era, we have a lot of positions or roles that were previously in person that are now hybrid or maybe done asynchronously. So how do you modify or adapt to a hybrid work environment?
Yeah, great. So I think an excellent example of that is actually something that has been around for a very long time. I don't know if people who are interested in population health are familiar with Project ECHO, but it was built through the University of New Mexico. And it actually started as like hepatitis C screening and like treatment. And what happened was that people at the main flagship hospital at the University of New Mexico, they identified liver specialists and other like important healthcare team members that knew a lot about HCV training. And then they looked at the rural population of New Mexico and they said, hey, there are a lot of patients in rural New Mexico that don't know how to like get Hep C treatment. And so they looked and they were like, these people cannot reasonably come into the hospital very quickly or easily. So they decided to create a model. It was a hybrid model back in the day when like hybrid wasn't really a thing. And so they found like small rural clinics, and they took the providers in those clinics and then they trained them. And they had these like hybrid conferences where those people at that main flagship hospital actually talked like directly to the people in the clinics, and they gave them their expertise. And so they worked together a lot through online skills. And so as a result of Project ECHO, what they found actually was Hep C treatment rates were like so much better in those rural clinics rather than they were at like the main flagship hospital. And then they took Project ECHO, and now it's like this huge, huge collaborative collection of like projects. And so it's in over 200 countries. And they have over 5.5 million like healthcare professionals who have like worked on different projects. It's had a huge impact on over 200+ million patients. And it's gone from Hep C screening to a lot of other interdisciplinary team work across the world. And so it's definitely possible. The way that they did that was they identified people who were really passionate about it, and then they had like recurring standing meetings. And so several times a week, they all had to be together on like this virtual call and talk about these patients. And so they like prioritize like the putting time into that. And time is hard for us as clinicians to buy into, but like the results were so impressive that people felt that it was really important. And so they kept doing things like this. And then more and more studies kept showing the value and benefit of that teamwork. Does that answer your question? Yeah.
Other questions? Oh, right there.
Thank you so much, Caroline. That was a great talk.
Nick.
You know, I was thinking about, you know, the difference between communicating in person and, you know, secure chat and everything like that. Did you come across, I guess, perception of communication in any of the research you looked at, how people perceived? Because you talked about like playing nice in the sandbox. I totally agree. It's hard to be mean when you're next to someone and talking. And sometimes I feel like that communication's better, but I'm not sure. I don't know if you saw.
Yeah, totally. I wish that they could do an intervention because I'm curious how Merida ICU is like pre-secure chat and post-secure chat, because I loved when the nurses marched into the room and just told me what to do. It was great. But I did see a few things. So when people felt like communication was poor and that they were mostly communicating through the electronic medical record, they felt like they were being forced into trying to practice team-based care. And as a result, that actually led to decreased job satisfaction and increased burnout. And so it's really important to kind of recognize that the human connection is a really important piece of all of this, where you get to talk to people kind of in person. Like there is something about us fundamentally as humans where we don't want to just like read what someone else says, and like we're also busy. It's so easy to like fire off a like message that seems like it's short, But in reality, that wasn't even what you were trying to do. It wasn't what you were trying to say. So Dr. Schiffler is actually telling me about this when we were having lunch the other day. It's like AI now has this tool where you can kind of give an idea as to the message of what you want, and then it like spits back out this flowery, beautiful message that is like all the kind, thoughtful words that you would have said if you had a lot more time. And so maybe that will be a part of our practice, and we'll all sound nice to each other, and then we'll all be happier. So we'll see.
Other questions from the audience here? We have none from online yet. All right, making me walk. Thanks, Ed.
Carolyn, really nice talk. You started your talk with a checklist and how you got really good at it. And when you innovate, sometimes it helps to innovate from something it's already part of the established practice. Tell me the extent that teamwork or identifying that as an important role is built into the checklist, or did you find that ever happened in your practice?
That's a good question. So I think when I started intern year, one of the things that people always told me was you should check in with your nurses before you actually go see your patient. And when I got busy, that was the first thing that went out the window. And so I feel like when you are busy, it is easy to forget everything that you have learned and everything that you have been trained on, and to just kind of think, I am the only person that can do this right now. It is me or nobody else. And so I think it takes a recognition that as you get older, like you're in healthcare longer, I think, like you recognize that like you have a lot of flaws and a lot of limitations. I feel like the biggest growth between me as an intern and me now is that I realize all the things that I don't know. And I don't feel scared as much to like ask for help in the same way. And that has like led to my appreciation of teamwork and collaboration. So that's not really an answer to your question, because I feel like I never put it into my checklist, but I was always told to do it. And so I can't imagine really an easy way to incorporate that into my checklist in a given day. Maybe you have some ideas. I don't know. I'd love to hear them, but I'm not very good at that. So.
Be time for one more question if we have it. All right. Well, if no more questions, certainly want to thank Carolyn once again for all she's contributed to the community here in the Department of Medicine and specifically to the residency program. So a lot of gratitude toward you. And I want to thank you for a wonderful Grand Rounds talk. So thank you, Carolyn.
Thanks, Andy.